Now that we've reviewed pressure support ventilation, as well as some of the challenges in trying to assess or maintain normal patient effort in pressure support, we will now introduce proportional assist ventilation on the Puritan-Bennett PB840 or PB980 ventilators. Proportional assist ventilation is a spontaneous mode of ventilation that provides support directly in proportion to patient effort. Unlike pressure support, with proportional assist ventilation, the patient's respiratory center has full control over all aspects of breathing, such as flow rate, tidal volume, and inspiratory time. In order to provide ventilation in proportion to patient effort, the proportional assist ventilation algorithm needs to be able to calculate the pressure generated by the respiratory muscles represented here as PMUS. PAV relies on the equation of motion, which we will quickly derive here from some simple respiratory concepts. Pressure total equals the pressure due to resistance plus the pressure due to elastance. Pressure total can also be written as P-vent, or pressure generated by the ventilator, plus P-mus, the pressure generated by the respiratory muscles. The pressure due to resistance is simply the flow rate multiplied by the resistance, and the pressure due to elastance is simply volume multiplied by elastance. So now that we have the equation of motion, and we know we need to solve for PMUS, let's fill in the rest of the variables. At any given time, the ventilator knows circuit pressure, the flow rate going to the patient, and the volume that has gone to the patient. To establish resistance and elastance data, the PAV software provides a 300 millisecond inspiratory hold just when the patient's effort has come to an end. This inspiratory hold maneuver is performed on each breath during the PAV startup, which takes at least 4 breaths. After the PAV startup phase, the inspiratory hold is repeated at random intervals to ensure we always know resistance and elastance, even if the patient's respiratory mechanics are changing over time. PAV uses the average of the last 4 inspiratory holds to calculate the resistance and elastance values used in the equation of motion. While pressure support uses a single arbitrary E-sense calculation once per breath to determine how the breath should be delivered, PAV solves for PMUS 200 times per second and provides support to the patient in real time as PMUS is being calculated. What you see here is an example of the 50% support setting in which the support provided by the ventilator is a mirror image of the effort made by the patient. The percent support setting is the main setting when using PAV+, and it determines how much the ventilator will amplify patient effort. At 50% support, the ventilator's share of the work to generate the breath is 50%, so the patient's share has to be the other 50% for an amplification factor of 1 times. Since PAV calculates the patient's effort, or PMUS, 200 times per second, the support provided throughout the breath will be at the instantaneous calculation of PMUS multiplied by the amplification factor of 1. This is why the circuit pressure above PEEP, when using a 50% support setting, should be a mirror image of patient effort. Now, if 75% support is selected, the ventilator's share of the work to generate the breath is 75%, so the patient's share would be the remaining 25%. This is a 3 times amplification factor, and you can see from the graphic how the pressure in the circuit would be amplified in proportion to the patient effort. Similarly, at the 80% support setting, the patient's share is 20% for a 4 times amplification factor. At 90% support, patient's share is only 10% for a 9 times amplification factor, and at 95% support, the patient share is only 5% for a 19 times amplification factor. Notice that at higher percent support settings, a small change in percent support leads to a large change in the amplification factor. In practice, this would mean that going from 80 to 90% support more than doubles the amplification from the ventilator, so the patient can decrease their effort by more than half and still maintain ventilation pattern as their respiratory center desires. The change from 90 to 95% support also more than doubles the amplification, so again the patient could cut their effort in half. As such, support levels above 80% support may be quite helpful in patients that are so exhausted or atrophied that they're unable to tolerate 80% support, but due to the high level of amplification, support levels above 80% should be used cautiously and probably only in patients that won't tolerate 80% support or less. Overall, the PAV percent support setting can be set anywhere between 5 and 95%, with a soft stop requiring confirmation to set levels above 80%. This slide shows how a patient's respiratory center should respond to changes in the percent support level setting. As you can see from the first breath shown here, the percent support has been set to 80%, which will provide a 4 times amplification factor. The patient's respiratory center will modify patient effort to target a desired tidal volume and breathing pattern. In this example, the patient settled on a 4 centimeter water effort, to which the ventilator applied a 16 centimeter water support above PEEP for a total of 20 centimeters of water pressure gradient to generate the breath. As such, we can see that the 20 centimeters of water is the total pressure gradient required to generate the breath that this patient's respiratory center desires. Let's see what happens in this example when the clinician changes the support setting to 75%. Since the amplification factor now drops to 3 times, the patient's effort of 4 centimeters of water only causes PAV to apply 12 centimeters of water support for a total pressure gradient of 16 centimeters of water. This lower overall pressure gradient would cause a smaller tidal volume to be delivered, which should cause the patient's respiratory center to increase their effort in order to continue to get the tidal volume the respiratory center desires. In this case, with a patient effort of 5 centimeters of water, the support delivered would be 15 above PEEP, and the total pressure gradient is back to the 20 centimeters of water necessary for this patient's respiratory center to get the tidal volume it desires. Similarly, if the clinician selects a 50% support setting, which has an amplification factor of 1 times, the patient would need to generate a 10 centimeter water effort in order for the total pressure gradient to remain at the 20 required to generate the breath the patient desires. A key point to take away from this slide is that the interaction between the percent support setting and the respiratory center should allow the clinician to adjust percent support to optimize the amount of effort being made by the patient's respiratory muscles, all the while allowing the patient to continue to receive the tidal volume and breathing pattern the respiratory center desires. When using PAV, there are 2 key alarm limits set by the clinician that are intended to limit risk of overdistension of patient alveoli. The first is the high pressure limit, which will limit the pressure delivered as well as truncate the breath if the high pressure limit is reached. In addition, there is the high inspired tidal volume limit, which will also limit volume and truncate the breath when the high inspired tidal volume limit is reached. These parameters should be set with the patient's safety as well as patient comfort in mind. Too low a setting on either of these parameters may truncate breaths frequently, leading to patient discomfort and nuisance alarms. Too high a setting could allow excessive pressures or tidal volumes to be delivered. Good clinical judgment should be used to set these alarms. Now that we've discussed how PAV works and how it's significantly different than pressure support ventilation, let's look at the additional clinical information that PAV Plus can provide. Since PAV applies a short inspiratory pause just as it sees the patient is completing their inspiratory effort, the compliance and resistance of the patient is calculated and displayed when PAV is enabled. Also, since PAV knows airway resistance, flow, and mouth pressure, it can calculate lung pressure. This calculation of lung pressure is displayed as a shadow trace that you may see on the pressure waveform when PAV is enabled. The display of intrinsic PEEP shows the amount of remaining lung pressure as calculated 100 milliseconds prior to the most recent patient effort. PAV Plus displays the patient's static compliance, while other spontaneous modes like pressure support do not. As such, in PAV, compliance can be used to titrate appropriate PEEP levels. This slide shows a 72-hour screenshot from a PB840 ventilator's trending page with patient compliance and PEEP being the selected trend parameters. This patient had been on the PAV Plus prolonged weaning protocol that will be discussed later, and initially was tolerating the 80% support setting well. As you can see, the PEEP level was weaned 3 times over this period from 14 centimeters of water down to 8. Also note that the patient compliance dropped from around 40 mils per centimeter of water to below 20 associated with those PEEP changes. While oxygenation was not affected significantly with these PEEP changes, likely due to hypoxic pulmonary vasoconstriction, the significant change in lung compliance was enough that the patient appearance was significantly distressed and no longer tolerating the 80% support level. Due to hypoxic pulmonary vasoconstriction, in which blood flow around collapsed alveoli is minimized, oxygenation may not be an adequate reflection of alveolar collapse due to PEEP changes. PAV Plus provides static compliance information in real time, which may allow for better decisions on PEEP changes during spontaneous ventilation than previously possible. Next, let's discuss the work of breathing bar that is displayed during the use of PAV. As you can see here, there are 4 colored zones. The green zone indicates between 0.3 and 0.7 joules per liter, which is considered the range of normal work of breathing for a typical healthy human. There are also 2 yellow zones indicating moderately elevated or decreased work of breathing levels, and there is a white zone indicating a highly elevated work of breathing level. There are 2 work of breathing flags that move around this scale. The work of breathing total flag shows the amount of work being done by the patient and ventilator combined. This would be similar to the amount of work the patient would have to do on their own if they didn't have the ventilator support. Next is the work of breathing patient flag. Recall from previous slides that allowing the diaphragm to do too much or too little work causes diaphragm injury associated with prolonged mechanical ventilation, and also recall how challenging it is to tell the difference between a normal work of breathing and no work of breathing at all, or anything in between, simply by visually assessing the rise and fall of the patient's chest during mechanical ventilation. As such, clinicians may find it valuable to have an indicator of patient work of breathing to be able to target work levels that are neither too high nor too low, and thereby aim to prevent the diaphragm atrophy and injury and prolonged ventilation associated with non-normal works of breathing. In this slide, we'll go over a fairly common clinical presentation you may see when transitioning a patient from pressure support ventilation to proportional assist ventilation. As you can see, the first breath is showing a pressure support breath. We have no indication at this point of patient compliance, resistance, intrinsic PEEP, or work of breathing level. As we transition to PAV, you can see that over the initial several breaths, the patient may have to modify their effort to get the tidal volume their respiratory center desires. In some cases, they may not need to change their effort much, or in other cases, there may be significant increases or decreases in effort required to get the tidal volume the patient wants. In this example, you can see the initial breaths in PAV were quite small and steadily became larger. There are a couple advantages of using 50% support to go through the startup phase. The first is that with the 50% support setting, the amount of support provided by the ventilator should be a mirror image to the amount of respiratory effort. And since the ventilator doesn't actually draw the green effort indicators shown in this presentation, one can estimate that the patient effort would be a mirror image of the support provided whenever the 50% support setting is used. As such, one may also extrapolate that the efforts made during pressure support are likely to be similar to the initial efforts made during proportional assist. This may be useful when assessing how strong the patient's efforts were in the previous mode. So once we get through the startup phase, the display will now show the work of breathing flags. In this example, the work of breathing patient is significantly higher than normal at 50% support. So the clinician may decide to increase to 75% support immediately after the startup. And after a few breaths, notice that the work of breathing patient settles within normal range. It's important to recognize that if a patient has significant atrophy, exhaustion, or diaphragm injury due to non-normal work of breathing levels previously, the patient may not be able to tolerate even a normal work of breathing for an extended period of time. In such cases, it may be necessary to rest the patient at below normal levels of work between attempts to normalize their work of breathing.